All right, well, welcome to this narrated PowerPoint presentation that summarizes some of the highlights that you're going to find in Chapter 9 of Loosening the Grip. This chapter provides us with an overview of the evaluation and treatment process. Recognize that for those of you who want to become substance abuse counselors, this really looks primarily at what I call the process of people coming into treatment. How do people get to treatment? What's the role of the counselor? Should somebody present him or herself for treatment services? Talks about the difference between screening and evaluation. Also talks about diagnostic criteria, ASAM patient placement criteria, and some of the task and big picture perspective on what happens and what you can expect should somebody come into treatment. So it sets the stage. It talks about what counselors do. As you get ready to begin, two things. One, as always, this summary is not meant to be a replacement for reading the chapter, so please make sure that you read the chapter in addition to listening to this narrated presentation. Number two is that I'm going to specifically try to speed up the discussion and shorten the PowerPoint. There's a couple of videos in this module that I think you can find really helpful, so I really want to shorten the time you spend here and give you the time to take a look at the videos that accompany this module in the online course. So the chapter is organized to provide us with information on these 5 areas. Talks quickly about a perspective on treatment, what we can expect. Talks about a distinction and identifying problems of use, the difference between screening and evaluation, what we do when somebody is screened and the screening is positive, and then if a person needs treatment or some kind of intervention, how do we treat people based upon the distinction of their problem? Is it an alcohol incident? Is it an alcohol use disorder? Those are the main points that we're going to find in this chapter. When they talk about a perspective on treatment, 2 things that they highlight that I'll highlight here. You should recognize that they talk about the fact that one of the most common challenges that we face if you're working in a substance abuse treatment setting is people who have a problem oftentimes don't recognize that they have a problem. They oftentimes aren't interested in getting help, and so we do face a challenge. How do we get people who need help to get help, to enter in our offices, to enter the treatment centers, to set their foot, to cross the threshold into our office to get the help that they need? And so people oftentimes come in because they've somehow been coerced or leveraged or forced into treatment, so we need to have some clinical strategies that will allow us to engage people when they come for help, even though they don't necessarily believe that they have a problem. The other thing that's important to recognize that's highlighted here is that not all substance use is diagnostically significant, so everybody who uses does not have a substance use disorder. And so we talk about the range of substance use. Some people are experimenting. Some people who experiment like it, they progress to using it on a social or regular basis. Some people go from there to have ongoing problematic use. They begin to experience problems as a result of their use, and if they continue to use, they then progress to the point that they can formally be diagnosed with an alcohol or substance use disorder. There is a question about physiological dependence, which you're going to hear discussed a little bit later in the chapter. So recognize that just because someone is using doesn't mean that he or she has an alcohol or a substance use disorder. The other thing that they highlight is that, so therefore, how we intervene and the necessity for the intervention is tied to how severe, how serious, how problematic their substance use is. This really is probably primarily a review. We should recognize, and you know this I think from the earlier chapters, is that even if you don't have a alcohol use disorder, anyone who drinks, anyone who consumes alcohol, or for that matter, anyone who uses any substance, is potentially at risk to have a problem related to their use of the substance. We do know that alcohol and other drugs are typically pretty strong and pretty potent pharmacological or neurological agents, so they do affect the individual. They affect our body systems across a lot of different areas. We also know that people who, when they use alcohol specifically, they can have consequences. It can be from a one-time or an acute use incident, or it can occur as a result of chronic heavy use. The example of the acute use problem, somebody uses, he or she drinks too much for the first time, they become intoxicated, perhaps they drink to the point of alcohol poisoning, which would be extreme. So they did not have an alcohol use disorder, but they consumed so much so quickly that they now are in medical danger because of their consumption of alcohol. The problems of chronic heavy use are things that we'll look more into this chapter, but so we have to recognize that problems in and of themselves are also significant, but one problem is not diagnostically important. What we end up looking for are repeated problems, recurrent problems, things that occur again and again. When we do an evaluation, we have to be open to the fact that some people will be non-problematic users or won't be diagnosed with a substance use disorder, and other people will have a diagnosable substance use disorder. Our recommended interventions will be based upon how they fall out on those scales. The author suggests that we look at alcohol use disorder or substance use disorder as chronic diseases. And for example, other chronic diseases that you're familiar with are diseases like diabetes and hypertension and chronic heart failure and things like that. So we have to look at it in the same way that we look at other chronic illnesses. And if we do that, then some of the things that are relevant to treating a chronic illness or chronic disease include the identification and understanding what the risk factors are. We have to understand what predisposes people to develop problems. Once we know those, we then can help them reduce their risk, identify and help them reduce the risks that they're facing. It also entails further monitoring of what's happening. If you know you're at risk, then there are certain things you can be doing on a regular basis to monitor your use, to monitor your health status, to determine if there's any kind of emergence or complications of, in this case, your substance use. And patient education, understanding what it is that they're dealing with, are essential elements of helping somebody who is facing significant risk factors monitor and moderate and reduce their risk. And this is pretty consistent with what we do when we identify people who are at risk for other chronic diseases as well. The author then moves into a discussion of the screening process first, followed by a discussion of evaluation. It is important to recognize that screening is not diagnostic. Screening is something that's done to help determine who needs further thorough evaluation. Sometimes the words evaluation and assessment are used interchangeably, so screening is very simple. Evaluation or assessment is thorough and is also diagnostic. Why would we implement broad-based screening first? Well, a couple of reasons. If the health condition is a condition that's common, and if the health condition is treatable, should it be identified, that's a good reason to engage in broad-based screening. If the efforts, what is required to conduct a screening is pretty easily available, readily available, minimal cost, minimal training required to implement it, then the effort is practical, and that's another reason to support broad-based screening. And then also what you are using to conduct the screening, the instrument, the tool, and what we're going to look at here are primarily paper-based instruments. The instruments themselves have to be valid and have to be reliable, have to be research-based and have demonstrated effectiveness. They're, quote, well-tuned, that it says, yes, we should use these, we can use these to help identify what it is we're screening for. So alcohol use disorder, substance use disorders all fit into this category, and so they would support the idea that we should do broad-based screening first, and then if people screen positive, there's always a threshold, then the person who screens positive would be referred for more thorough evaluation or assessment. If we look at alcohol use disorder and substance use disorder, a couple of possible screening approaches that are acknowledged in the text. One is the potential to do laboratory tests. Those are fairly expensive. We'll talk quickly about those. The other is to use what we typically use, primarily paper-based screening instruments that are either clinically administered or self-administered. We'll also talk quickly about some web-based instruments as well. When they talk about laboratory tests as a possible screening instrument, recognize that what they do is they look to detect the presence of either medical complications that are due to heavy drinking, or they can be medical complications due to heavy substance use of other substances, and typically they're looking for markers, for biomarkers, for indicators that are sensitive to the consumption of alcohol or other drugs, depending on what you're looking for. And there's a number of examples that are listed in the chapter. They're also listed here. What you should recognize, and what they talk about in the chapter, is that laboratory tests are fairly reliable. The challenge is that they're more cost prohibitive. They can be very expensive. They require specialized time to administer. So from a screening perspective, it's very, very unlikely that you're going to see laboratory test used specifically as screening instruments. Laboratory tests are oftentimes used as confirmatory information when we're doing a thorough evaluation or assessment, but much less likely to be used from a screening perspective. We don't send people for a lab test to screen for the presence of a substance use disorder. As we begin to talk about and look at the screening tests that are covered in the chapter, it is important to highlight this here. Number one, recognize that a screening itself is basically a simple instrument that's meant to determine who should go for a further evaluation or assessment. Screening positive doesn't mean the person does have a substance use disorder, and so they're not considered diagnostic in and of themselves. They're considered to be indicators of who should go to have a diagnostic assessment conducted. They help identify somebody for whom that closer exam, the eval or assessment, is appropriate. Not everybody who screens will screen positive. If you screen and you screen negative, typically no further referral is needed. If you screen and you screen positive, then there is further referral for the evaluation assessment that is indicated. So people will go in one of two directions after the screening is conducted. Because they're simple to administer, the author suggests, and I would agree, that healthcare settings, behavioral healthcare settings, should routinely administer screening tools because they're easy to administer. They help to early identify somebody in the process who may otherwise not be identified until their substance use disorder has gotten to a much further developed stage. In the book, you're going to find a fair discussion of the paper-based screening tests that are listed here: the CAGE, the MAST, the TWEAK, the AUDIT, and the CRAFT. The CRAFT you'll see as an adolescent-specific tool. The other ones are not specifically for adolescents. They're almost all what I call acronyms. CAGE stands for 4 questions: concealed, annoyed, guilty, and eye-opener. But read the discussion of all these in the text, recognize and be able to identify them and what their purposes are. They all are used commonly in healthcare settings, especially in non-clinical settings. If you're working at a treatment agency, you're unlikely to administer these tools, but if you're working at a primary healthcare setting, at a mental health setting, at another setting, you're much more likely to be exposed to these tools. The author does also talk about web-based screening. Obviously, in recent years, because people have access to the internet, at one point, web-based and internet-based screening was not feasible. Today, it really is feasible, and so there's a number of websites that allow people to access a screening instrument. One of the nice things about that is that it provides feedback to the person at the time they complete it as to whether or not their responses suggest that they have a harmful pattern of substance use, of alcohol use. It also gives people a frame of reference on how they compare to other people, because it's all aggregate data that they can then use to place a person on a scale. And then it also typically closes with some brief interventions that help the people make some changes in their drinking patterns. We're going to talk on the next slide about what's called the brief intervention itself. There's a tool called, and an initiative that the SAMHSA has initiated called SBIRT, S-B-I-R-T, Screening, Brief Intervention, Referral, and Treatment, which has been very, very productive in helping intervene with people who have alcohol and drug problems. So screening and brief interventions go hand in hand, and they're a way to help people get help that wouldn't otherwise get help. You'll see in the module page there's a link to a website out of Canada that has a screening tool, an alcohol use screening tool, and so you'll be required to go to that, to complete it, to experience it, not to share your results with me, but to get a feel for how a web-based screening tool does work. You're going to see in the chapter that there is a discussion about the elements of brief intervention. As I said earlier, the feds have initiated, and it's really been probably 10 plus years now, using the power of what I call professional discussions. If you see a healthcare professional and there's some indication that you have a drug or an alcohol problem, many times healthcare professionals didn't have a conversation with their patient about that. And so this really said, look, there's some simple things that healthcare professionals can do in a discussion with their client that will prompt them to get help that typically wouldn't happen when a loved one, with a friend, when a family member has that same discussion. So familiarize yourself with the process of brief intervention. They talk in that about, in order for the feedback to be effective, there are some common elements that make it more effective. It's called frames. You'll see the acronym here. F is feedback about the patient's personal risk. R, responsibility of the patient, i.e. that he or she is responsible to do something. A is to be explicitly providing advice to change. M, provide a menu of ways to reduce their drinking, so give people options, let them make some choices. E is to be empathetic, to have an empathetic counseling style. And then S, self-efficacy, optimism. Let the patient know that you believe he or she can do this. So you're going to see that further described in the chapter. Be familiar with the common elements of brief interventions that seem to make them more effective if you incorporate those in that process. The author then moves into looking at a couple areas that when somebody is in the midst of a screening process, what are the situations that would require immediate medical attention, things that the clinician or the person administering the tool would then say, okay, wait a minute, we need to bump this up urgently to get medical help right away. It includes an overview of their general health status. There can be health problems that are unrelated to their alcohol or drug use, i.e. Diabetes, hypertension, trauma, fractures, a lot of things that are not necessarily drug or alcohol related that the person may disclose that require immediate medical attention. So we always need to be mindful of that. For drug and alcohol users, we also have to be mindful of their potential for going into withdrawal. Are they currently intoxicated, or do they have the likelihood of going into withdrawal? A number of factors indicated here that you're taking into account as you listen to somebody's alcohol and drug use history as to whether or not they are likely to experience withdrawal. Withdrawal always requires medical intervention, and so we would make an immediate referral or arrange for immediate medical attention. The author does talk about the fact that we're not looking simply for alcohol use, so we also have to be mindful of the person's use of other substances. They also talk, and it's important, I think, for you to recognize that our clients will know more about what's happening and what's available in their world, in their drug-using world, than we do, and also names changes, substances come and go, and so they talk about the fact that your client may talk about using a substance that you're not familiar with. Instead of playing it off and pretending we know what they're talking about, we're better off, number one, saying, hey, I don't know what that is, tell me more about that, because while they may be surprised that we don't know, it's more important that we understand what they're using and what the potential problem is than to pretend we know and not take action because we really didn't know how serious that substance use was. So important discussion, take a look at that. They also give a whole list of some physical symptoms that are indicative of the need for immediate medical evaluation. Some are highlighted here, but they're all listed on page 255, so take a look at that as well. We also have to be mindful of suicidal or homicidal thoughts, intent, ideation, and so anytime we have a concern that the client is potentially dangerous to himself or herself or to other people, we typically have a professional obligation to intervene as well. Once the screening has been conducted, typically, if they screen positive, we then are going to be in the point of having to make a referral for follow-up care. It may be internally to a program that you're working at, it may be externally. So they highlight the fact that in order to make effective referrals, what's most important is two things. The clinician involved, the counselor involved, has to be active in making the referral versus passive. They also have to be assertive. Again, like I said, compare that to passive. When referring clients to specialized programs, to say to somebody, okay, please call this number, you should call them and set up an appointment, they are not necessarily likely to follow through on your recommendation. Instead, you have to use your relationship with the client. You also have to know what program or programs would best meet his or her needs. So you have to be knowledgeable about local facilities, local resources, programs, and their personnel. You may know there's a particular counselor who specializes in what the person needs to address, and you may want to give your client that person's name. We can't just hand them a slip of paper or a phone number and say, hey, call them and make an appointment. Ideally, we're actively involved. We can help them set up the appointment where they leave your office. We don't want to leave it up to them. We want to really facilitate the referral. Ideally, if they're going to leave your office and go elsewhere, you want to have the referral in place and the appointment set up before they leave your office. And then we follow up. There's ongoing contact and support for the client. We pass them off or we turn them over to the other personnel, to their agency, once the referral has been solidly made, but we can't simply give somebody a referral form and say, okay, good luck, and not follow up. So they describe it all in the chapter. It is good clinical practice, and more importantly, it more likely assures that your client's going to have a positive outcome as a result of their contact with you. The author then goes on to talk about the concept of patient engagement. In recent years, treatment programs, clinical professionals have been mindful of what's called patient engagement and then patient retention. Engagement is the idea that if somebody comes to an agency for help, it's very, very important that he or she become welcomed and actively involved and engaged in services as quickly as possible. If somebody comes in, is not actively engaged, they're more likely to leave treatment, to not be engaged, to drop out of treatment, which correlates with poor treatment outcomes. So as you can guess, and they talk in the chapter, ultimately the best way to engage clients in treatment is to develop a relationship with them. It's to make sure that we convey that we care about them, that we're here for them, that we support them, that we understand them. There's a discussion of the concept of motivational interviewing. You'll see throughout your training regular reference to concepts like motivational interviewing, motivational enhancement. The idea is that everybody who comes to see you is motivated to be there for some reason. And so what we have to do is understand why they're coming to see us and tie into that motivation as a way to engage them actively in the treatment process. There are some specific suggestions here. How do we do that? Well, we express empathy. We have to accurately understand them. We also help what they call develop discrepancies, meaning if the person says, I want to do this, or I want to be this, I want to be successful in school, and the person's drinking or using is causing them to drop courses or to fail in courses, then we point out the discrepancy. Hey, I know you want to be a success in school, but you've now had to drop your second course because of your alcohol and drug use. So we look for disconnects between what they want to have happening and what's happening as a result of their substance use in particular. They talk about the fact that it's almost always, it's hard to say never, but arguments, it's rarely productive to argue with a client. So avoiding arguments goes hand in hand with rolling with resistance. If the client is unwilling or resistant to a certain strategy, to a certain step, we don't continue to confront and to cajole them into following through. We instead acknowledge that resistance and we join with them on that. So, okay, that's not what you can do right now. So what else can you do, and what can I do to help you decide differently, and things like that. So we don't argue, we don't cajole, we don't intimidate, we avoid the argument, we roll with the resistance. And just like the frame's perspective, we also support their sense of being successful. We support their self-efficacy. You can do this. I have faith in you. I'm confident in you. You will be able to do this. They then proceed to talk about what's called the stages of change model. You'll sometimes hear this as a trans-theoretical stages of change model, originally set forth by James Prochaska. Ultimately, he worked a lot with another theorist, Carlo Di Clementi, so you will either hear it referred to as Prochaska or Prochaska and Di Clementi. It's really a model that is based upon the idea that motivation unfolds in separate and discrete stages, and that these stages occur in the change process for anybody who's making a significant change in their life. Behavioral changes like stopping the use of substances, weight loss, those sorts of things. The model does say that people, while it's a discrete stage model, which we'll talk about in a second, people can sometimes go forwards and then backwards. And so it isn't always a linear process. People will cycle back and forth between various stages. The other thing about the model says that if we understand where the person is at in the process of making a change, there are certain interventions we can do that are more likely to help them move through that change process. There's going to be a total of 5 stages of change. Those 5 stages are identified here. The person will go from pre-contemplation to contemplation to determination to action to maintenance. Again, people can cycle back and forth, so they may go from pre-contemplation to contemplation to determination, back to contemplation, etc. So recognize that it would be nice if people go from 1 to 2 to 3 to 4 to 5, but people can go from 1 to 2 to 3 to 2 to 1 to 2 to 3. You get the idea. We're going to quickly look at all of these. What you're going to see in each of the 5 stages is something like this. So top talks about what's the characteristic of the client, and then the bottom is, so based upon what the client characteristic is, what's an appropriate intervention. So in this case, pre-contemplation is defined as a stage where the person really hasn't thought about or recognized the need for him or her to make a change. So they're thinking, I don't have a problem. I'm not even sure what you're talking about. If they come to you, it's because somebody else has suggested or identified that they have a problem, but they have not yet identified or accepted that they have a problem. So our task, the counselor's task, is to basically help raise awareness of what people are concerned about, help them start to question whether or not they may or may not have a problem. We want to raise doubts and help them move from pre-contemplation, not thinking about it, to the next stage, which is contemplation. Contemplation is where the person now is starting to say, okay, well, maybe I have a problem. So they've thought about it, they're thinking about it, they're now ambivalent, they're not convinced that they have a problem. They're just saying, well, maybe I have a problem. Maybe I need to take a look at this. They also the ambivalence is in part based upon the idea that they can see both positives and negatives to changing, which also means that the positive to changing is a negative to not changing and vice versa. So there's positives and negatives, or pluses and minuses about changing or about not changing. So the person is really kind of weighing those decisions there. And so our task is to help them weigh. We want to tip the balance as they weigh those decisions in the favor of making the change. If we're hoping they decide to cut down or to stop using, we want to help tip the scale in the direction to motivate them to decide they're going to go ahead and make a change. So it's kind of a risk-benefit analysis, pros and cons, and we want to help focus on determining, making the decision to make the change. The person moves ahead from contemplation. The next stage is called determination. It's really the decision-making point. The person now is less ambivalent. There still may be some uncertainty, but they've now really come to the realization. They've determined that I do have a problem and I need to do something about it. And so they now start to be willing and eager to do something. So our job is to help them determine what they should do and how to get those things going. So what do you need to do? Here's what I suggest. Or here's where I look to find those answers. If that's successful, the client will move to the action stage. At this point, the person has already made the decision. They determine they need to change. Now they're taking action to make the change that they already decided to make. So they have a plan. They've developed a plan ideally with you or with your treatment program, and so we're helping. The client is engaged in following up on that plan. They're now doing something about the problem, and so we want to do everything that's suggested here. We provide assistance, we provide support, we provide encouragement, we provide direction. We're really trying to support them early on, in particular, with the action that they've determined to take to address their problem. If we're successful, if they move ahead, they will move to the final stage, which is called the maintenance stage. The action has been successful. The person's saying, hey, I can do this. This is working. They now want to maintain those changes. It's still relatively new early on, so they now need to learn how to incorporate these changes into my lifestyle on a regular basis. The fact that they're being successful reinforces a change. So success at making the change in and of itself becomes reinforcing. At this point, we continue to support them. We also then help them look for the potential problem areas. We look at the possibility of relapse or return to use. And we also help them develop relapse prevention plans, because our goal is to be proactive. We want to help them maintain the change in a way that will support their continued, in our case, ongoing abstinence and ongoing recovery. If a person has been screened positive, I want to talk briefly now, and the author talks about the whole evaluation process. If somebody proceeds from screening to evaluation or assessment, we always use, or typically, you're going to be using a standardized assessment tool, ultimately which helps with diagnostic criteria. It helps make decisions about patient placement. It also gives us an idea about what we need to do from a treatment planning perspective. It's also a starting point in terms of their current status, and so it's a yardstick. It's a way to determine if treatment is having the intended outcome. We're looking for people to get better and not to get worse. The initial interview is really going to be used to get an overall generalized picture of the client. It's important to recognize that assessment or evaluation is a never-ending, ongoing process. We do assess someone at the time they enter treatment, but we continue to reassess throughout the whole treatment process. You will know more about the client after their first week than you do on their first day. You'll know more about the client after the first month than after the first week. And so we're constantly getting updates. We're constantly collecting information about our clients to really ensure that we have a thorough understanding of who they are, an accurate understanding of who they are, and we've kept track with the changes that have occurred during the course of their involvement in treatment. They do suggest that we involve the family in the evaluation process, which is essential. It's the norm when possible. Recognize that in some cases you don't have access to family members, and so we try to get the family involved, but we can't always do that. If we can't do it, we look to do as much as we can to get a complete picture of the client and to recognize who else can be helpful as part of his or her treatment and recovery process. Continuing to look at the evaluation process, clearly part of that is always going to be an examination of or gathering information about their history of substance use. Pretty basic information here. It's always important to recognize that we're going to get better information if the person is comfortable both emotionally and physically. That also includes, are they comfortable physically in terms of their substance use? If the person's currently intoxicated and or experiencing withdrawal, then they're not comfortable, and we're not going to get good information. We're not going to get reliable information. We may need to implement medical interventions until they become comfortable. So recognize that the person's ability to respond accurately in the assessment evaluation process is driven in part by how they're feeling emotionally, physically, etc., to allow you to get information. Certainly basic information here. Every substance use history is going to gather information about what the client drinks and or uses, onset of use, when did they first use, how long have they been using, quantity and frequency of use, both recent, and then also we look historically at periods of heaviest use. We will see people's use patterns change. They may have been getting high early on, 14, 15, 16. They're now 22. They don't get high as often, but they're using more alcohol. So we're always looking at both recent and lifelong patterns of alcohol and drug use. We're also looking for problems, when, where, and whether it caused problems in any area of life, family, legal, job, school, etc. It's a comprehensive look across all life domains as a part of the evaluation process. As we gather the substance use history, we also want to try to engage not in a hard and fast clinical evaluation, tell me, but instead talk to them, can you tell me more about? So it really should be gathered in a conversational tone as opposed to being gathered in kind of a hard and fast driven, almost an interrogation kind of thing. It's also important to talk in the chapter about everything we do, and you'll hear this probably multiple times, everything we do has to be collected and written down. It goes into a patient chart. That's for a variety of reasons. Primarily, the chart is meant to reflect the person's progress and process, what happens when he or she enters treatment, why do they come to treatment. It helps to not only capture what happens in the treatment process, how they did or didn't respond. We also detect whether or not their drinking and using patterns have changed over time. Because it's what every clinician involved is going to work with, it provides information not just to you, but objective and meaningful data to other clinicians as well. Typically, treatment is offered as part of a treatment team, and so it's important that all members of the treatment team have access to a complete and thorough history of the client. You're going to see a brief video in this module that reviews the DSM-5 diagnostic criteria for both alcohol use disorder and substance use disorder. A couple things that I'll highlight here is that the DSM-5 criteria, which is a current diagnostic and statistical manual that programs use to identify whether or not somebody has a substance or an alcohol use disorder, contains 11 criteria. So you really become a detective. When you talk to your client, you're listening for symptoms, you're listening for things that have occurred as a result of his or her drug use. There's a total of 11 criteria that are included, and depending upon their responses, in order to diagnose them with a substance use disorder, they have to be positive for at least 2 or between 2 and 3 criteria. In that case, we say that they have a mild substance use disorder. If they have 4 or 5 criteria positive, we call it a moderate substance use disorder. If they're positive for 6 or more of the criteria, we call it severe substance use disorder. And we also make a distinction between substance use that does or does not have a physiological dependence, which is indicative or indicated by withdrawal. Criteria are identical for all substances, but substance specific. And so what that means is if you have a client who uses alcohol, cocaine, and marijuana, we first talk about his or her alcohol use. We use the same 11 criteria and look for how their alcohol consumption has affected them. We may find 4 of the criteria present for alcohol use. We then go back and talk with the client about his or her cocaine use, and we evaluate and listen for criteria specific to cocaine use. There may be 2 criteria there, and then we listen to their same criteria for cannabis use, and maybe there's 6 criteria there. So for that person, they would have moderate alcohol use disorder, mild cocaine use disorder, and severe cannabis use disorder. The criteria are all the same. It's that we diagnose substance specific. Key point, be familiar with that. The criteria are described in more detail on pages 262 and 263 of the chapter. So take a look, but begin to wrap your head around the use of DSM-5 criteria for diagnosing substance use disorders. The other thing that's important to say is, so therefore by default, when you assess somebody, if there are 0 or 1 criteria present, no criteria present, or just 1 of the 11 present, then he or she is not diagnosed with a substance use disorder. So they have to have at least 2 criteria, and as you see here, 2 to 3 is mild, 4 to 5 is moderate, and 6 or more is severe. So begin to understand and wrap your head around this concept as you think about conducting substance abuse evaluations. Once you've determined whether or not they have a substance use disorder, we then determine what level of care is needed. And in Illinois and in many states, that decision is based upon using standardized patient placement criteria that were developed by the American Society of Addiction Medicine, or ASAM. They basically have organized their assessment into 6 dimensions. They're all listed here: acute intoxication and withdrawal potential, biomedical conditions or complications, emotional behavioral conditions, complications, which is actually emotional, behavioral, and cognitive conditions or complications, the person's acceptance or recognition of the need for treatment, the likelihood of relapse or the likelihood of continued use, and then lastly their recovery environment. So there's again a video in this module that does a nice job of explaining the ASAM criteria. So take a look at that module. It will help you understand these 6 dimensions and how to use them in more detail. ASAM looks at just not only 6 dimensions, but they also look at these 5 levels of care. So once you conduct an assessment across those 6 dimensions, the outcome of that assessment then determines what type of intervention the person needs. Interventions are always provided in the least restrictive environment. So for an individual who does not have a substance use disorder, then he or she doesn't need treatment. They qualify for what's called a 0.5 or an early intervention ASAM level of care. Again, those are not treatment clients. They don't have a diagnosable SUD. If the person has a diagnosed substance or alcohol use disorder, then he or she will be treated in one of the remaining 4 levels of care. Level 1 is outpatient, least restrictive. Level 2 is intensive outpatient or partial hospital programs, more restrictive than level 1, but not as restrictive as level 3. Level 3 is inpatient or residential services. You're in a place for 24 hours a day for some undetermined time period. And then level 4 is really hospitalized or hospital-based care, medically managed intensive services. So again, in the ASAM video, you'll be exposed to these in a little bit more detail. You want to become familiar with the idea that treatment is always provided in the least restrictive environment, and also that from an ASAM perspective, level 0.5 is not a treatment program. It is a early intervention program for clients who do not have a diagnosable substance use disorder. The next two slides, this slide and the following slide, talk about compare the harm reduction model or harm reduction approach to what is more traditional abstinence-based model or approach to treatment. And so take a look as you read that chapter, recognize that there are treatment interventions that are not necessarily abstinence-based, and harm reduction is the most common that people would refer to that is not an abstinence-based approach. It basically says that we have to understand the person's use in the context of kind of their whole being, their whole environment. It moves away from labels like diagnosing, etc., and instead says we need to meet the client with where he or she is at. We're not going to impose the expectation of abstinence on him or her. Instead, we're going to start to listen to what are they doing and how does their use fit with their life. How does it support what they need to do, and how does it get in the way of what they need to do? As a part of that, therefore, so when somebody comes to a client or a counselor, who's working from a harm reduction approach, the expectation is not the person is going to commit to becoming abstinent, nor is the expectation that they will be abstinent if they seek treatment. Instead, we look at what can they do to basically be in a better spot, what can they do to reduce the risk of harm to themselves based upon what they're doing. There is still an importance of developing a therapeutic relationship with the client. We still have to tie into their self-efficacy by using their strengths to foster the change that they want to see foster. In terms of the fourth bullet point here, their use falls on a continuum of harmful consequences. We have to recognize that, and that's the difference in this model from an abstinence-based approach, is that therefore we have to redefine success if you work from a harm reduction approach. Success in an abstinence-based model would be that the person becomes abstinent. Success in a harm reduction model might be that if the person was consuming a fifth of whiskey a day, if he or she can cut down and use a fifth of whiskey every 2 days or every 3 days or once a week, that is in of itself positive change, is change in the right direction. And so therefore we don't define success as abstinence. We redefine success in the context of what it is the person wants to get done. The next couple of slides will compare and contrast how we respond when the evaluation has indicated that we're dealing with either an alcohol incident, which is discussed here, in comparison to the next slide, which we'll take a look at what do we do if there is the diagnosis of an alcohol use disorder. So as you can tell, the biggest distinction is that for it to be considered an alcohol incident, there obviously has been some problem related to their use or consumption, but the assessment, the evaluation says that it is not diagnostic. They cannot be diagnosed with a substance use disorder or an alcohol use disorder. And so this is where the person would be referred for what's called early intervention. It is not treatment. It's a 0.5 level of care using the ASAM criteria. The caution here is a couple things. The clinician has to assume, or not assume actually, that the incident itself was enough to change the behavior. So even though clients will come in and they'll talk about being embarrassed, etc., we have to recognize that even though they've been through this uncomfortable incident, that in and of itself was not necessarily enough to change their behavior. So we provide them with information and education about choices and consequences, about how to reduce their risk, things like that. And then we offer follow-up or ongoing monitoring once they've completed typically what's considered a short-term intervention. This is a comparison to alcohol incidents, i.e. non-diagnosable substance use disorders or alcohol use disorders. In this case, we're now looking at somebody who does meet the diagnostic criteria for an alcohol use disorder. There are some assumptions that we're going to make, is that it's a chronic condition, that there has been a pattern versus isolated incidents of high-risk use, that they're now experiencing more than one negative consequence as a result of their substance use or their alcohol use, and the person, at this case, the person has lost control, although there may be some difficulty at assessing their loss of control. In this case, the recommendation is going to be some level of care, some formal treatment intervention, and as you saw earlier, and we'll look at in this module, looking at treatment in the least restrictive environment, i.e. outpatient level 1, intensive outpatient or partial hospital level 2, residential or inpatient level 3, or medically managed intensive inpatient or level 4 treatment. So treatment referrals, treatment recommendations, will specify what level of care the person is to be treated at that is going to be most effective at interrupting their use of the mood-altering substance. If the person is in fact receiving treatment or enters treatment for alcohol or substance use disorder, then these are really some of the common things you would expect as a counselor or as a clinician. We're going to be looking at life patterns and how their use has affected them, developed or led to the development of dysfunctional life patterns. We want to help them become functional life patterns, how they've begun to use their alcohol and or other drug use as a primary or major method of coping, some emotional or psychological wounds, oftentimes physical problems, medical problems, which in some cases are correlated with the person's age. For younger clients, for adolescents, for example, there oftentimes are far fewer medical or physical dysfunctions or physical complications. For middle-aged to older clients, or for clients who are using in high-risk manners, clients with injection histories, things like that, there's likely to be more physical or medical problems that are noted. For most people involved with substance use disorder, we can expect to see some kind of deterioration in family or social functioning. Family is defined by who they're involved with. They may no longer be involved with their family of origin, but if they have other people who are significant in their life, we're oftentimes going to see challenges or problems that have occurred in those relationships as a result of their ongoing alcohol or other drug use. And then following up on treatment issues to be anticipated, we're also then going to look at helping the person learn or relearn their skills of daily living, and in particular in how to do things without using. We're going to have to make sure that we acknowledge what they do during the course of treatment, i.e. progress, accomplishments. We have to help them reflect or readjust memories and not live through sort of slanted memories or distorted memories, but be able to retrieve actual memories. Help them learn how to manage the emotional extremes, the mood swings, the ups and the downs, and help them to become more balanced. We'll certainly have to take a look at how their use has affected their relationships, and in particular issues of connectedness, interdependence, dependence, intimacy, which are typically interrupted in a problematic way when a person's using substances, and certainly helping identify not so much reasons. They talk about reasons for drinking and using here, but we're really looking more, in my opinion, at alternatives to drinking and using. If they were using as a way to manage emotions, we want them to learn how to find other healthy ways to manage emotions. So we try not to get caught up, or I try not to get caught up in reasons, but more try to get caught up in alternatives and how they can use healthy behaviors to substitute for what the alcohol or drug use was doing for them. One of the things that they talk about in the chapter is the recognition that relapse is in fact something that is not uncommon, and so you can often expect to see it. It's common in all chronic illnesses. Recovery is typically not a straight line, but an up and down line with starts and stops and progress and slips or fallbacks. So expect it as a clinician. We have to recognize it does happen. For people who are newly sober or newly in recovery, they're certainly at higher risk of relapse, in part because they sometimes underestimate how difficult or how challenging it will be. People come to treatment, they think that's it, I'm cured, I'm fixed, I'm better, and they minimize the need to stay involved with recovery supports after treatment, which oftentimes can be more than their new sobriety can handle. So it's not, unfortunately, uncommon. We work at integrating relapse and relapse prevention into treatment programs, helping people recognize what they need to do both towards the middle and end stages of treatment, as well as how they're going to manage that once they have formally left the treatment system. We also have to recognize that there is a retriggering of shame and guilt, so that if people do relapse oftentimes and they've already left treatment, it can be challenging for them to make a decision to come back to treatment. So we have to recognize that it is difficult to re-enter treatment after relapse, but it's our job to keep those doors open, to establish those relationships, and to encourage the client to use our services even after he or she has formally left treatment. The last couple of slides will take a look at the importance of looking at, quote, outcomes. And in particular, we always, quote, assume that treatment is having the desired effect. What they will talk about in the chapter, and what's important for I think clinicians to be aware of, is that while we expect and assume that our services are having the desired effect, it really is important to measure outcomes in a realistic, valid, and reliable way, and then be able to compare outcomes over time, not only internally within the agency, but also compare outcomes across systems, compare what happens to people who get treatment versus people who don't get treatment, compare what happens to people who finish treatment versus people who don't finish treatment. So we really need to have structured ways and rigorous ways to follow up on people. Most treatment programs don't have the ability to do outcome studies, and so as you enter the field, you want to familiarize yourself with the different indicators that your program is using as a way to determine whether or not the outcomes that they are intending are in fact outcomes that clients are experiencing as a result of engaging in treatment with that organization. When we look at treatment outcomes, one of the things that I would highlight is highlighted here is that part of the important part of treatment is clients do better in treatment when they perceive their counselor to be competent, to be knowledgeable, to be empathic, to be supportive, and so don't minimize the importance of how you are perceived when you work with clients and how that will influence their outcomes. If they perceive you in a positive way, then they're more likely to have better outcomes. If they perceive you as being incompetent, unqualified, uncaring, they're likely to have negative outcomes. So how you establish that relationship is really going to be critical to the ultimate success that your client will have as a result of being in treatment. And also related to that is that we have to learn how to be both mindful of and to manage our emotional responses. We have to, there is recognition, there are manualized treatment approaches, i.e. the matrix model and actually 12-step facilitation therapy. And so the more we adhere to standardized approaches, manualized approaches, the more likely our clients are to get better versus counselors who like to what I call wing it. They don't have any particular approach or particular style. They do one thing one day and one thing the next. And so there really is value of having a standardized approach to what you do. Our style will either enhance or get in the way of developing a connection to our clients. So our own interpersonal style is really going to have an impact on engagement and retention of clients and treatment. The development of what's considered a therapeutic alliance, i.e. The therapeutic relationship between us and our clients, is also going to obviously have either a positive or a negative effect. When we do develop an alliance, it has a positive effect. The inability will have a negative effect. And then very simply, there is a correlation between how long a person is in treatment, how long they're involved with us, and how well they do. As you might expect, in general, the longer a person is in treatment, the more they follow recommendations, etc., the more likely they are to have a positive outcome as a result of their treatment episode.